Dr. Tara Kiran. Introduced her really quickly during our first session. I just want to take a quick second to share her bio with you because she's an impressive, wonderful woman. She is a family doctor at St. Michael's Hospital Academic Family Health Team in Toronto. She is the Fedani Chair in Improvement and Innovation at the University of Toronto and Vice Chair of Quality and Innovation at the Department of Family and Community Medicine. Tara investigates how changes in the healthcare system impact the most vulnerable in society. In her research and practice, she develops and tests solutions to make healthcare more inclusive and more effective. As well as all of this, Tara is also OurCare's principal investigator. And while I'm not sure where she gets the time and the energy to do everything she does, I'm deeply appreciative for everything she does do. Okay, so with that, Tara, I'm going to hand it over to you. And I'll stop sharing screen so you can try sharing yours.
Great. Thanks so much, Jasmine, and welcome everyone. It's so wonderful to see you all today, and I can't wait to meet you in person in Winnipeg. I'm looking forward to sharing with you some of the work today that I've been doing and pulling together with the help of others to really try and understand kind of how primary care might be able to look different. Just getting my slides loaded, and Jasmine, can you confirm, can you see these all right? Perfect. Yeah, so, today I really want to focus on what Manitoba can learn from other countries when it comes to primary care and other provinces, because one of the things that I'm learning more and more about is how diverse primary care is actually across Canada. And you can see that actually in the proportion who don't have a family doctor and how that's different across the country. During my presentation today, I'm going to be sharing with you some statistics that are from a few different sources. One source is the Commonwealth Survey. And so I'm going to be sharing with you data from the Commonwealth Survey, which is a survey done of 11 different countries. It's done every year, but they use a different population every year. So I'm going to be sharing results from 2019 when they surveyed the general population, I think in 2020, where it was that they surveyed primary care physicians. So we'll be looking at both those perspectives. And I'm also going to be sharing some data that our team has pulled together. And our team has actually been looking over the last few months at different countries that have, we say, what I would call higher performing primary care systems. What I mean by that is that more of their population has access to a regular primary care practitioner or place. And so what are some of these countries? Well, you can see Canada there and how it's faring compared to some of these other countries, including France, Germany, New Zealand, UK, Denmark, Netherlands, Finland, Italy, and Norway. I'm going to be doing a deeper dive on some of these, including the UK, the Netherlands, Finland, and Norway, where we've been able to meet with folks to better understand their systems. But to start, how do some of these countries compare to Canada when it comes to some metrics? Well, when we looked at a whole bunch of metrics, there were a couple that really stood out. The first question that a lot of people ask, well, is are we having struggles with accessing primary care in Canada because we just don't have enough family doctors? Well, actually, the answer is that we have about similar numbers of family doctors in Canada as they do in some of these other countries, or at least the way that it's been measured. So compared to these other countries, Canada is kind of in the middle when it comes to the number of family doctors per population. But one thing, actually, if you go deeper into the data that becomes interesting is that although Canada has similar numbers of family doctors, or what are sometimes called general practitioners, Canada actually has fewer total doctors per population than all of the other countries that we've been talking about. And so what that means, to some degree, it seems, is that family doctors are taking on other roles within the system that in other countries might be taken up by people in different specialties. So the numbers are a little misleading. Not all family doctors in Canada are actually practicing comprehensive longitudinal office care, the kind of care that we're often thinking about when we're thinking about people needing a family doctor. About 30% or almost a third of family doctors in Canada are actually practicing in specialized areas. This includes emergency medicine, sports medicine, and some others are working in walk-in clinics. So all told, even though it looks on these numbers that the proportion of family docs is about average, it's actually probably not the right way of counting, because many of the people who are classified as family doctors in our system are actually not doing family practice care in the way we think about it, and instead doing these other specialized areas. So when we look at some of this data, we can come to the conclusion that, one part of the problem is that we don't have enough doctors, and I think that's true. But more doctors alone is not going to get us where we want to be. And our team, looked across these different countries, and I've pulled out a few different themes that I'm going to go into a little bit more depth today. But in short, like, some of the key issues that are different in Canada also include things like the amount of funding that we have, whether that funding is public or private. So actually many of the other health systems that we've talked about, they have a higher proportion of total health spending that is public. It's about the way the system is organized, whether doctors are held accountable, how practices are organized, and the information system. So we're going to go through some of these one by one. But to start off, let's talk a little bit about funding. When we compare Canada to 22 comparator OECD countries, we can see that Canada actually spends a smaller proportion of the total budget on primary care compared to almost all of these countries. So the average amount of the total health budget spent on primary care from these OECD countries is about 8.1%, and in Canada, it's only 5.3%. So some of the issues that we're just not spending enough money. But it's not just all about the money. It's also how we're organizing care. So interestingly, when you look at some of these other countries, they make finding a family doctor or nurse practitioner easy. In fact, you don't really actually have to go and find one. In places like Finland, you're actually automatically registered to a local clinic. Everybody in the population is. And in Norway, you're automatically registered to a specific general practitioner. And that doesn't mean that you don't have choice. It does. So in each of these countries, there are provisions for how often you can change. So I think it's in Finland, you can change maybe once a year. In Norway, maybe it's twice a year. And so a certain number of times a year, you're allowed to change and pick a different center. But what that means is that nobody is looking or seeking to find a family doctor because they don't have one. Everyone is guaranteed access because they're automatically registered to one. In the UK, they have a slightly different system. There, you're not automatically registered, but rather the local clinics in your area have to accept you. And so, for example, when I lived in the UK for a short period of time, we were there and we had a list of like 3 or 4 clinics that were nearby that we could just go to, and they had to accept us. It wasn't like they had a choice or that we would be on a waiting list. In the Netherlands, things are a little different. So they aren't automatically registered. You do have a choice of local general practitioners. And in fact, you're encouraged to have someone that's nearby. But if the general practitioner is full, the insurance provider actually has an obligation to help you find one. So contrast that to Manitoba and Canada. Generally in Canada, you're left to find your own family doctor. In some provinces like Ontario, you can search a public website to see, which family doctors are accepting new patients. I don't think you can do that in Manitoba. In Manitoba, as in some other provinces, you can register with a service. In Manitoba, it's Family Doctor Finder to actually, get a doctor if you don't have one. But unfortunately, the waits can be really long, and we see this in many provinces. So although technically the government is saying that, yes, we'll help you find one, practically speaking, it's not really working. So another thing, that is, I would say, a strength, though, in Canada is that generally speaking, when we are setting up our family practices, we have a very good ongoing relationship with a family doctor and or nurse practitioner and their patient. And as we'll see, the ongoing relationship is actually really important. But in some of the other countries, that's not true. So in Netherlands and Norway, it is the case that there is an ongoing relationship with the family doctor. You're seeing the same person over time. But in UK and Finland, where you're registered to a practice, you're not necessarily seeing the same doctor or primary care practitioner over and over again. In many of these other countries, the care is encouraged to be close to home. Now in Manitoba or Canada, you can in theory choose any family doctor, and sometimes you might travel long distances to see them. Another feature that's different, I would say, relates to team-based care. So in Finland, nurses are the first point of contact, and nurses in the UK, for example, often independently provide some aspects of care, like well baby visits. And there are other health professionals that are increasingly part of the team. So for example, physiotherapists or psychologists in Finland. In Ontario, actually, about 25 to 30% of the population in Ontario is attached to a family doctor that is working in a team-based setting. So for example, I work in one of those teams. My patients can see me, but I can also have them see social worker or pharmacist, nurse or nurse practitioner who actually all work in the same clinic as me. And those other practitioners help me to, I think, deliver better care, and they obviously directly help my patients. There's a lot we need to do in Ontario to improve that model. So as I said, not everyone has access to a team-based care. And, there's ways in which we definitely need to make the care more efficient because, for example, it's still the case that in Ontario, often the first point of contact is the family doctor, and the family doctor then refers you to another health provider, and then the other clinician, often gives add-on care as opposed to taking work away from the family doctor completely and seeing a visit independently. So, instead of a nurse doing a diabetes visit and then the family doctor not having to see the patient with diabetes, often the patient will see both the nurse and the family doctor, which can have its advantages, but maybe is not as efficient in a time where we have limited resources. So all this to say that Ontario is actually ahead of other provinces, some other provinces in terms of the proportion of patients who have access to a team, but there's still a long way we need to go. Now, where are we at in Manitoba? And Amanda and Alan can jump in here at the end of our presentation to correct me, but my understanding is that about a third of the population has access to a practitioner who theoretically has access to a team that's part of My Health Teams. It's different than the case in Ontario in the sense that these team members who are part of My Health Teams are not in the clinic, but they are more like at a regional level. And the practitioner would have to refer specifically to these other individuals. It's not integrated with the same patient record as it is in Ontario in true team-based care. Now, there are, though, some centers that do provide team-based care in Manitoba. An example of this are centers called access centers. There are a number of them in Winnipeg. I think there's some outside of Winnipeg. And this is where care is integrated, actually, not even just with other health professionals, but other types of services as well. So I think that including social services, for example, or dental services. There are, I think, also some NP-led clinics and some pilots. But for the most part, I don't think clinic-based, team-based care has spread as far as in some other provinces. So another contrast is after hours. It's been really interesting to see internationally that many of the countries, for example, in the Netherlands, they have very regionally organized after hours care. There's actually one number to call. So if you're in, you live in the Netherlands, you know what number to call if you need care after hours. You call that number and you get in touch with a nurse. The nurse actually figures out, do you need to be seen this evening, or can your problem wait, for example, to the next day? And if you did need to be seen this evening, they would kind of figure out which is the closest place to go, or maybe they would even send a driver and a physician there to see you. The physicians actually all take turns in this kind of rotation, covering the evening or after hours clinic. And in fact, I think many felt like that was an improvement from them just covering after hours for their own practice, where they had to be on call more. Now, because it's shared among a large group of physicians, it's not actually too onerous. And then as a result of these, like they have both like some accountability for same day, next day access in the clinic, as well as after hours. There are actually few to no walk-in clinics, which is really interesting. Contrast that to on Manitoba, where I think there's minimal to no after hours obligations among the physicians. Some physicians may choose to work together to organize coverage. There's definitely some walk-in clinics. So remember, if a physician's working in a walk-in clinic setting, primarily that means they can't actually, that is time that they're not spending in a primary care practice seeing people on an ongoing basis. In Ontario, there actually is more accountability for after hours. So anyone who's part of one of the new models of care that were introduced 20 years ago, though they have we have obligations as doctors to provide a certain number of after hours sessions. But it's still not as organized as it is in Europe. And many family doctors do work in walk-in clinics, of course. So we can talk a little bit more about how family doctors are paid differently and also how the clinics are run. So in the UK and Netherlands, family doctors are often paid by capitation, and in areas like Finland, it's salary. And then there's some financial incentives for improving quality of care. So what is capitation? Capitation is pay per patient per month or per year, and often it can be adjusted based on the age or sex of the patient. It may be adjusted by complexity. It's a very different way of paying than pay by the visit, which is the traditional way of being paid in family medicine. So in Ontario, for example, there's still a lot of family doctors who are paid by the visit. There's some capitation though now, although the capitation itself is not adjusted for complexity of patients, which is a bit of a problem. And there are some incentives in Ontario around quality. Now in Manitoba, about 2/3 of family doctors are paid fee for service, and the remaining third have alternate payments. Often these are like an hourly wage but I will say that a new contract is under negotiation between the government and the medical association, so this may actually change. So different ways of paying doctors, and I think often people say that, if doctors are paid by capitation or salary, it gives them different kinds of incentives to potentially spend longer time with patients and take more of a population view or a preventive view versus focusing on getting, often if it's paid by the visit, you're really, the incentive is to see a lot of people, but see them fairly quickly. So you can imagine that how you pay doctors makes a difference. And then I think another interesting difference is, how the clinics are owned and operated. So in some countries like Netherlands and Norway, physicians do own and operate their own clinics. But in Finland, actually, many work at a health center that is run by the government. I would say in Manitoba, it seems that most primary care clinics are owned and run by doctors, although there are a few run by the regional health authority. I think the access centers would be examples of that. And so in Ontario, again, most clinics are owned and run by family doctors, but the team-based models are generally actually nonprofit organizations. So when it comes to accountability and governance, that's where actually we see a really big difference. There are really strong incentives and accountability for quality of care or same day, next day access in European countries, some of the European countries we've been talking about. And in the Netherlands, as an example, like there is accountability about, whether a doctor where the doctor can practice and what type of practice they can have. So as a family doctor there, you can't just decide, okay, I'm going to set up in this neighborhood and only focus on sports medicine. But of course, in Ontario and in Manitoba, doctors have a ton of freedom and they can choose to practice anywhere they want to, and they can choose pretty much their own scope of practice. So they can choose, I'm just going to set up a practice focused on sports medicine or fertility medicine or vein treatment. And there's really very little accountability often about the amount of patients you need to take, or any, although there's incentives for quality of care, there isn't accountability as much for that. Interestingly, so not surprisingly, in these other countries in Europe, you're seeing very few family doctors doing specialized care compared to Manitoba and Ontario. No one difference in Ontario and Manitoba. I would say in Ontario, the team-based organizations do have reporting requirements on quality and other measures. But physicians themselves have little practice accountability outside of the after hours. In Manitoba, I think there's really actually even less accountability than I just described in Ontario. So when we can look at some data to kind of get a snapshot of where we are in Canada. This data map here, gives a snapshot that in Canada, about 65% of doctors are practicing in a group setting, and about 15% or just have a practice where it's just themselves, maybe with a receptionist. About 12% have a community health center. It's a little different in Manitoba. It looks like in Manitoba, actually, there's more doctors practicing in a community health center, community clinic model, which is nice to see. Fewer in a group in a group physician setting, but about the same in private practice, where it's just one doctor, I should say, a solo practice. What's the difference between a solo and a group practice? Well, often we actually see is that if you work in a group practice with other physicians, those physicians who work with other physicians are more likely to be able to offer appointments on the weekend and use nurses and case managers and use electronic medical records for things other than billing. So they're often practicing in a way that we know is able to provide a different level of quality of care if they're in a group practice with other physicians versus a solo practice where it's you're the only physician. What we see when we look at after hours is, I would say when we look across Commonwealth countries, so these are like 11 comparator countries who are part of, including the US, but many other countries in Europe, we can see that most of the Commonwealth countries, 75% of physicians will say on average that there is an arrangement for after hours care. Contrast that to Canada, where it's only about 50% say that they have an arrangement for after hours care. And in Manitoba, it's much lower. So only 28% of physicians in Manitoba are reporting that they have an arrangement for after hours care. So this is a snapshot related to other kinds of access from a patient perspective. So from a patient perspective, we can see, only 38% of folks in Manitoba are saying they can get a same or next day appointment. Contrast that with 57% on the Commonwealth average. Only 35% say it's very or easy to get care after hours. Contrast that with 48% in the Commonwealth average. And so here, I think Manitoba is doing similarly to Canada, maybe slightly worse. But in general, Canadian patients are less likely to report being able to get that timely access. I think one of the areas that really stands out as well is information technology. When we were doing our deep dives into the Netherlands and the UK and Finland, we could see that there's much more possibilities for e-communication with patients. For example, online booking and secure messaging is much more common in the Netherlands. They often are using, for example, in the UK and the Netherlands, their electronic systems to manage care proactively. And for example, in Finland, the patients and their healthcare practitioners can access their record quite easily centrally. So it's not that this record is just held by your one clinician and patients can't see it, but rather, with the right precautions, patients can actually access their own record. In Manitoba or Canada, of course, we can see that very few use online booking or secure messaging in physician practices. One thing that's great in Manitoba is it does seem like there is a provincial electronic record with imaging, labs, immunizations, some encounters with primary care and summaries of primary care, although not the full primary care chart. So there's some, you know, information that's available provincially to the clinicians at least, but other areas do remain siloed. And we know that our electronic medical records in Canada are not as conducive to allowing us to identify, you know, which of our patients are in need of certain care. So, you know, one thing that's good is in Canada is that we are, you know, most of our physicians now are using electronic medical records. So that's 88% in Manitoba, which is just slightly below the Commonwealth average, but around the Canadian average. But, you know, we can see that compared to other countries, far fewer physicians offer patients the opportunity to communicate with their practice via email or a secure website. So Canada's right there at the bottom. Only 23% of physicians say that they offer that to their patients. And only 22% of Canadian physicians say that they offer their patients the ability to request appointments online. And you can see that contrasts quite poorly with other Commonwealth countries. So again, you know, very few Manitobans can view test results online or request prescription renewals online in comparison to the Commonwealth average. And similarly, you know, it's although this is actually better than the Canadian average, there's still a smaller proportion, relatively, I'd say low proportion of Manitobans say that they can, that family doctors say they can electronically exchange patient clinical summaries with doctors outside their practice, lab tests outside their practice, or medications. So this is doctors communicating with other practices. It seems like it's better in Manitoba than in Canada, but still it's a minority of doctors who are able to communicate these kinds of things with other doctors very easily electronically. And then this is just a snapshot of whether family doctors can use other personnel to care for patients. This is the idea of team-based care. And what we can see here is, you know, far fewer in Canada can do that than in other countries. One thing as we end, I wanted to just mention to say that one thing the Commonwealth doesn't do is really provide data on how countries compare when it comes to continuity or that relationship. So we've been talking a lot about the importance of primary care as a relationship-based care. And we know that relationship actually means better outcomes for patients, less healthcare use, better quality, less spending. And in general, actually, in Canada, we see that our continuity of care is high. So in summary, in Canada, we spend less on primary care than comparator countries. We have similar numbers of family doctors, but fewer doctors total, and more of our family doctors are doing specialized work or working in walk-in clinics. Our comparison countries organize care differently. They often have more geographically based care. The physicians are more accountable. They're using more interprofessional teams. They have shared regional after hours and better use of information technology. There may be some trade-offs though. So for example, in some countries where there's guaranteed access to a primary care clinic, there's lower relationship continuity. So you may not see the same doctor over and over again, even though you're guaranteed access to someone, it may not be the same person over and over again. And we know that that's a trade-off. So I look forward to taking some questions. I think there's probably lots in the chat there that I haven't kept up with. So over to you, Jasmine, to moderate.